a shunt. So it's always better to, if you can, obviously to have to be operating at the time when the ventricles are smaller.
Brilliant. Thank you very much. Dr. Caceres, it's all yours.
Are you able to see my screen now?
Yes, yes, thanks.
Okay, all right. So I have no financial relationships to any commercial interest related to this presentation. And I will just try to make a case today on just a second here. Folate fortification based on these following premises. One, hold on, that screen, that we have 30 plus years of evidence since the British Council published its results on the effects of fortification, that it is effective because it decreases not only the total number of cases, but it also decreases the severity of cases that we get to see, that is completely economically viable, that it should be part of every sustainable development of national policy, it's safe, and it's ethically mandatory. And why is that? Let me go to my next slide. Oh, my screen is frozen. Okay, so we know that spina bifida prevention is important because many populations do not have access to socialized healthcare and are underdetected or untreated. And that we also know that many populations will not terminate pregnancies due to personal or religious beliefs. You know, when I was training in Chicago, one of the great surprises to me was the fact that we had a lot of Mexican immigrants, a lot of Polish immigrants. Both populations were deeply Catholic and did not have any health insurance. And both populations would not terminate their pregnancies, even if spina bifida was detected prenatally. And we know the economic burden of war and post-COVID economics that are displacing populations all across the globe. So this is a true problem. So we know that there's approximately 300,000 kids born worldwide every year with spina bifida. So this means that we could have prevented, since the data from the British study evidence was published, about 10 to 12 million patients could have been prevented. So these are staggering numbers to think about. And of course, an unknown number of miscarriages, stillbirths, and abortions. And in those kids which are born with spina bifida, we know that it's an elevated cause of mortality, disability in children and young adults, and with unknown healthcare costs in adulthood due to transition of care issues. And of course, in many countries, and we know this as a matter of fact from the experience of our colleagues in Africa, that sometimes they're overburdened by spina bifida cases. And there's a clinic that's ongoing on a Saturday. They got to operate on 20 kids with spina bifida that have been awaiting surgery. So it's not only draining resources, but manpower that prevents other areas of specialized neurosurgery being developed just because of these cases. Now, we have spoken about spina bifida today, but I would like all of you to consider that this is the most severe congenital malformation that's compatible with life. Any other thing that's more severe, the kid will die shortly after birth. But spina bifida, even if untreated, they will continue to live, as we have heard. It's a chronic high-risk disease because of hydrocephalus, renal failure. These kids are prone to fractures and soft tissue ulcers and infections. They will develop restrictive pulmonary disease associated to scoliosis. And of course, they have many quality of life issues in the psychosocial arena throughout their lifetime. So talking about cost, we know that in the United States, Samer spoke about this. It has been calculated that it's a $1.4 million per patient in the US. There was a study done in Europe, in Italy, that it said that approximately it's €500,000 throughout their lifetime, and that the family will absorb 37% of that direct medical cost. And the cost of associated complications, shunt infection is the highest cost of medical device-related infection. It's around $50,000 per episode. Once a shunt gets infected, the child has to go back. The shunt has to be externalized, has to be placed on an EVD, has to receive, at least 10 days of antibiotics. And if you start adding up, this cost is quite significant. If they go on to require hemodialysis, now we're talking about $90,000 annual cost. Kidney transplant, almost $500,000+ Spinal instrumentation, $140,000. So it overwhelms the neurosurgical workload, the cost containment of neurosurgical equipment and devices that are required, the management of neurogenic bladder, the chronic management of rehabilitation. All of these are significant costs for the patients. So what are the components of a good fortification policy? Well, number one, we should all strive in these challenging economic times to have a universal healthcare system. Then building a good congenital anomaly registry. We need to know exactly how many defects are being born so we can know the impact of our policies, because, believe it or not, politicians and especially health officials are driven by data. If you cannot tell them how many patients are out there and what is going to be the impact of your policy, it's very hard to convince people. And then you should conduct a pre-fortification diagnosis and survey of folic acid deficit. This is done by taking blood samples of women, hopefully from, urban and non-urban areas, and then trying to know what the situation is. Then establishing a cooperative relationship with the food industry. And then fortifying according to the alimentary patterns of each country, doing an active surveillance of food staples, measuring economic impact of the fortification, and involving stakeholders in these policies. And also involving champions of fortification, which means, we as neurosurgeons, we always think that our place is within the operating theater or the outpatient clinic. But as I will show you, we still have a very fundamental role in society. We're often looked as champions in medicine. Nobody will challenge the neurosurgeon in its social position, up the ladder. We're leaders. So what we have to say is heard, and it's very important for health officials and for laymen. So why is that, my very small country, Costa Rica, is very significant in fortification policies? Well, I'll tell you why. One of the main things is that, we're roughly 5 million inhabitants. 1 million of those are children. 98% plus of all pregnancies are delivered in screen hospitals. We're a very stable population. There's no legal abortion, so abortion is not a common option in Costa Rican women. So we know exactly how many kids are born with spina bifida. And the public healthcare system has free healthcare for all pregnant women and their children. And every single child that's born with spina bifida will be evaluated, treated, and followed at a single central children's hospital, which is where I work, the National Children's Hospital. So just to be clear, in my country, no adult neurosurgeon, no pediatric surgeon will touch a child with spina bifida. Every single case comes to us. So we have a very good grip of knowing how many kids are born with these, what happens to them, and we follow them throughout their lifetime. And the other thing is that all produce is centrally retrieved, fortified, and returned to the population. So we started in 1998 fortifying wheat flour with 1.5 milligrams per kilo of wheat flour. Then cornmeal in 99 with 1.3, milligrams per kilogram. Then we fortified dairy in 2001, and then rice. So we're one of the few countries which actually fortifies for staples. And we started fortifying with wheat flour as opposed to some other countries, as you will see in this chart, because our population really follows this European tradition of eating more bread than tortillas. So this is just an example of why you want to, start your fortification according to the alimentary pattern in each country. These are the countries in the world that fortify. As Samer has said, we still have a lot of areas to go. You will notice that Europe is still missing a large portion of it. Some countries do believe that the best way to prevent spina bifida is just to terminate pregnancy, but we don't think that's an option if you can provide fortification. Now, I think this is the most important slide in my chart. You will see how in 1990 we started fortifying and how there was a significant decrease of more than 50% in the number of cases, and how as the other staples in food were fortified additionally, how we have maintained this post-fortification rate that is less than what we started with over the last 20 years. The same happened with child mortality. You will see that it is very significant. It's not an observational effect, and how that rate has been kept very low over the last 20 years. Now, not only that, look at what happened, for instance, at the rate of the decrease of it is 76% total decrease of neural tube defects after fortification. So we wanted to look at what happened with our patients, and we did a study of 400 patients that were followed at the spina bifida clinic at the National Children's Hospital. Roughly half of them were male and female. The average gestational age at delivery was 39 weeks. 57% were delivered vaginally, and we proved with that there was no significant difference in rupture in the myelomeningocele, whether they were born as a C-section or vaginally. As you can see here, 72% of the patients are retrieved and taken to the Children's Hospital and operated within the first 24 hours, 11% within 24 to 48 hours, roughly less than 2% less than 8 hours. That's when they're born at the hospital that's next to us, and 50% 8 to 12 hours. So most of the patients are operated within 48 hours. So what was that we saw? We saw a caudalization of the myelomeningocele defect, not only in anatomic but functional levels. There was also a decrease in defect diameter, and we had non-existent neurotubal defects associated kyphosis. I can honestly tell you that I have not seen a single case of kyphosis in the last 20 years. So that is quite significant. And we also had a dramatic decrease of symptomatic neonatal Chiari malformation. Most of our kids are able to walk with AFOs. So that's the distribution of level. The orange level is roughly, you will see that most of the kids are L3 and below. And this is a busy chart, but if you look at this, you will see that roughly most of the patients, 58% are middle lumbar. So most of them are L3 and below, 58%, and 13% are low lumbar, and 6% are sacral. We only had a 1% non-closable, what we consider really large lesions that we could not close. You could see that 1%, these are two cases that were not conceived in Costa Rica, but rather in Nicaragua, where there's no folate fortification, that came with a kyphotic deformity. And we only had 2% cases of symptomatic KRE2 patients. Now, shunted hydrocephalus did not change a whole lot in our experience, but this was because of a trend within some attendings in my department. Now, I'm going to scroll through this just to show you that we wanted to see, and there has to be a very active surveillance to know that the industry is not taking a step back. You will not believe in how many countries of the world the component of the industry is a main role player, and they will try to cut corners. So you have to surveil that not only they start fortifying, but they continue doing it. We listen time and time again, that, oh, if we fortify, we're gonna lose some of our earnings, and if you don't surveil them enough, with time, some of these millers will stop fortifying just for the sake of saving pennies. It's a pity, but it's the reality. So these are the classic cases that we get to see. So as I said, only 3 cases of symptomatic KRE at the birth required decompression. And as we know from the McClone data, most of these cases do very bad, even with decompression. And this is basically because the brainstem is already having bad wiring. We had 4 cases of kyphotic deformity. 3 of these cases were conceived outside Costa Rica, and one was one of the cases from the early series. Shunted hydrocephalus, pre-fortification, we used to shunt more than 94%. Then 79% were shunted after post-folate fortification. But this is because 2 of the older attendings still believe that shunting was the way to go. So we are slowly changing this. We're doing more ETB. And of course, we have to look very carefully at the outcomes. So why do we still have spina bifida after folic acid fortification? Well, we know this is because of tetrahydrofolate enzyme polymorphisms. And this is because the PAX gene and some other genes that are involved. So sometimes even you will see a family which has had offspring, normal offspring, 2 healthy kids, and then they go on to have a child with spina bifida, even with adequate folate levels. We know this is an enzymatic process that sometimes gets in the way, but it's very interesting to know that when you're fortifying, not only you are, affecting the mother, but you're also giving folate to the parent, to the father of the child. So you're covering both aspects of their offspring, both components. We know, as you can see from these studies, that the rates of childhood leukemia and some other diseases did not change after folate fortification, because believe it or not, there are many detractors in many areas of the world which will tell you that folate fortification increases the rates of autism and leukemia, colon cancer, and some others. We know now, as a matter of fact, that when done properly within safety levels, there is no impact of folate fortification on all these so-called diseases. So what did we learn? That we need to standardize the surveillance of birth defects, that we need to establish partnership with public and private health providers in order to get good data. We need executive mandates to enrich several staples, to have a strong partnership with industry, and we have to inspect and have vigilance of compliance. And we need to survey blood levels of folate in the future knockout variants that could contribute to neural tube disease to learn more about this. So this is a teamwork of several agencies and disciplines. Now, I would just like to end just by underlining how ridiculous is the cost of fortifying. fortifying a ton of flour cost around $5. And if you calculate what the cost is going to end up being for the consumer, is less than 1%. Less than 1% will be the total cost. Millers will argue that this is way too much for them. And then you realize, the economics of this huge problem that for pennies, people refuse to fortify in many areas of the world that could prevent this terrible disease from happening. We know that by a study done in Chile, that the annual cost of fortification are covered, the whole policy is completely covered by just the prevention of just 2 cases, right? And that the impact of acid fortification in the US saves around $400 to $600 million each year. So prenatal surgery should be established when you have exhausted all the chances of prevention. The so-called reduction of chiari, that we can attain by fortifying. The less severe hydrocephalus, we know that we can also decrease that by fortifying because the defects will not be as severe. There's an improvement in IQ, there's an increased maternal and fetal risk. It's 3 surgeries. There's multiple personnel. It's a very expensive procedure in some countries. So you should only try to attempt this once you have exhausted all the chances to prevent it by using folate. And this is where GAPS-BIF comes in. Already Samer has spoken about this. This is an alliance with the ISPN, with some of the stakeholders from the food industry, from the World Healthcare Organization, from people from public healthcare are involved, and we all collaborate in order to try to deliver these programs. We know now that we're active for trying to fortify salt in some areas of India and Africa, because salt is it does not decay, and it's easy deliverable to some areas, and it's ubiquitous. So this is one of the areas that we're exploring now. There are many published articles of what we have achieved. I would like to inform you that we were successful in convincing the World Health Organization 2 years ago in order to declare that fortifying should be mandatory in every country. And with this, we would like to drop these rates throughout the world with the help of all of you. So with that, I would like to conclude, and I would like to thank you for your attention. I will take any questions that you can have now.
Thank you very much, Dr. Caceres. That was a fantastic talk on folate fortification. Professor Rocco, do you have questions on folate fortification? Or
my comment is just that I find very provocative to conclude that we should start with folic acid fortification before starting thinking about antenatal program, but you are completely right, Adrian. This is something that is very important, because instead of curing one, we cure hundreds. So it's really convincing, and the problem is to try to convince the industries, the authorities, and so on, which is not so easy. And we all seen all your efforts and the efforts of ISPN and at the WHO and so on to try to move on that, and RAM publication and work too, of course. So thank you very much for this really inspiring and showing us as how neurosurgery is not just in the operating theaters. Thank you.
Thanks. Thank you. Mr. Thompson, do you have any comments, thoughts?
Yeah, I mean, I suppose certainly to echo for it. I mean, I think Adrian, you and Jeff. I mean, it has been an amazing effort to which I mean, absolutely, you should be applauded for that. I was interested to see though that you say even if you don't prevent the neural tube defects, the dose effect of actually lessening the consequences, I think, was an interesting thing coming out of your data, because clearly there are some women who are going to have a genetic predisposition to having an open neural tube defect fetus. But as I say, to see that you now don't see kyphosis, you see slightly less severe Chiari, I think is an interesting finding. And I suppose the other thing is I wanted to just go is if you deliver folic acid through salt, as far as we're aware, do we know is it just as efficacious? Can you get enough folic acid in through salt fortification?
I still have to say that I don't know the final outcome of that. The study is being done in India, and I know in Africa there are 2 countries where this is still deployed. I don't have the final answer to it, but it is a promise. It is a promise because, I mean, you can always argue that in some areas of the world, having wheat or rice, they're already economically challenged, but that salt is ubiquitous, right?
Yeah, sure.
So it's going to be very interesting to see the data that will come out of that.
All right. No, thank you. Thanks very much.
Thank you. Fieggen, do you have any comments or questions?
Yeah, thanks, Naren. Adrian, yeah, always very inspiring to hear you talk. And it just, I guess the big mystery is why there is this resistance. I mean, the evidence is so overwhelming. And as you say, only 25% at the moment of pregnancies in the world benefit from preconception folic acid. It's incredible that, I mean, I really thought a few years ago when all this effort really sort of got going that it wouldn't take much effort to shift the dial, and things haven't really changed yet. Do you have any sense of why it's taking so long?
So I think there are several misconceptions that we need to fix. Number one misconception, it's actually in the medical world. People think that pregnant women actually take folic acid to prevent spina bifida, and that the effort is already being done. And this is false. For all the trainees and for all the people who are not dealing with this on a daily basis, you should know that we actually give folate acid to women who are pregnant to prevent anemia from pregnancy. Once you discover you're pregnant, your neural tube has already been closed. So you need to do it prenatally. And we know from studies in the Scandinavian countries where people are more educated, I quote, that less than 20% of pregnancies are planned, and therefore, trying to take folate prenatally as a personal decision is not a good way to prevent spina bifida. It fails time and again. So just putting it in the food of people is the way to go. So that's one of the things that we need to change, this misconception in the medical world. Number two, for some reason, there are some crazy ideas that stick to the people, right? Number one, if any health official, you tell them about folate fortification, they will tell you, oh, but isn't it related to autism? I don't know why this idea has stuck for so long. And we have the numbers to prove that that is not the case. The same happened with colon cancer. And then the other thing that we have seen in many countries is that everybody says, we need to run our own data to see whether this is going to be effective. And like, why? I mean, we have worldwide data that proves that this is effective. Why would you want to run again the study if we know this is effective worldwide and that the cost is completely ridiculous? Well, there's always this backlash. And then the industry, you will not believe how many times we have sat with millers and we're talking $5 per ton, and they will tell you that, oh, if we spend $5, we're gonna lose some of the profit that we make and that we have very shallow margin. And then you start to realize that, yes, we physicians are good-willed, but that in some other areas of human enterprise, that goodwill is not always going to go the extra mile. So it's always a challenge, but it should be us as neurosurgeons who should be pushing this politics, who should be talking to politicians, to health officials to make this happen. If we can prevent a single child, we are saving them a lot of money. This is what we have to prove for the long run. So I commit each and every one of you who have listened to my talk to, push this policy forward. We need to prevent this terrible disease. Did you know that we have, do you actually know how we came about the polio vaccine? The polio vaccine was obtained because President Roosevelt, it was said that he suffered, polio, and that was the reason why he was left in a wheelchair. And the Marchozymes was created in order to come up with a vaccine to fight this paraplegia epidemic that came from polio. Now we even have a cheaper vaccine, which is folic acid, to, contain this epidemic of childhood paralysis that it's ongoing worldwide. And it's cheap. It has been proven, it's safe, it's viable. Why are we not doing this? I commit every and each one of you to think long and hard about this. Thank you very much.
Thanks. Please, Mr. Thompson.
John, sorry, just one fact. So it just occurred to me while you speak. These guys who are making flour, they're in industry, as you say. They haven't got any. I mean, let's face it, probably haven't got much of a public commitment. Are there any scenarios do you know of around the world where governments will reimburse them, or the government will fund them to put the folate in the flour? Because as I say, if you leave it to industry, I can imagine you're bashing your head against a brick wall.
So, at least in my country, they will get reimbursed. But let me tell you about this, Dominic. Food International and some other agencies will move in any country where there is this desire, because the machine that you need to put the pellets of folate into the milling, it's worth around $5,000. And that's like once in a lifetime investment. And then it's $5 per ton.
Mm.
So, and as you saw, it's less than 1% of added cost to the total. So it's ridiculous,
Mm.
But that's when you realize that, we just need to make it more economically viable decisions.
If I may ask the last question, is that, do you think that there's a lot of buy-up from the actual countries, the neurosurgeons from countries where there are no fortification? Are you going from outside to influence the countries? Do you think that there's enough momentum coming from the neurosurgeons in the countries where there's no fortification?
I think there is, to some extent. We need to make this message more heard throughout the world, because one of the things is that, public health officials publish and read their own journals. We neurosurgeons read our journals, and sometimes the word doesn't get out as much as we would like to. We need to make this message heard across the society, among most medical schools. We need to teach this at a basic level so everybody knows about how we can actually, make a difference. Because if you ask any of this to an adult neurosurgeon, very few will care or know about this. This is mostly pediatric neurosurgery, but we're trying to make, a change out there slowly. I think we're gradually overcoming that. At least, I will not get tired to deliver this message as much as needed, as long as it makes a difference.
Yes, that's great. Thanks. I think if I'm right, Mr. Thompson, I think D.H. Lawrence with Hugh Keynes came up with a helmet, I think it might be good that I think the neurosurgery curriculum is already full, but an idea of public health neurosurgery being instilled along the way. I remember I was at a conference in India. This was 21 years ago, and Professor Gol was in front of me. It was a neurotrauma conference, and he had a nice cartoon. He said, if we can just keep operating all the time, that's fun, but fine. But if you don't try to sort out the road traffic accidents, then there's little point be operating day in and day out. I think there is a role for obviously neurosurgical societies, but individual neurosurgeons, maybe neurosurgeons have to think that it's nice to do glamorous operations, but also it's good to engage with public health. Dr. Caceres, there's a small question for you on the chat box. If you may please answer that for me, I'll be grateful. So this brings us to the, Samer, do you have a question?
A quick question for Adrian. First of all, fabulous presentation. I cannot thank you enough for summarizing this noble work done worldwide, led by you and other colleagues. Is there any way, Adrian, to quantify the combo effect of doing prevention with folic acid and fetus surgery? Let's put it this way. Let's look at a country, any country in the world, with a spina bifida situation, numbers, incidence, prevalence, outcomes. Then this country, you put it through fortification of folic acid, you reduce the numbers, and the cases you could not prevent, you start a fetus surgery program, and for selected cases that qualify, and you operate in them. 10 years from now, this combo effect of prevention plus fetus surgery, how can that lead to changes the status quo? Numbers, outcomes, finances. Is there any way to do it?
I think that would be us because of all the the features that I just told you about. Centralized efforts in a public healthcare system where, it really doesn't matter. Offering cost does not, it does matter, but you're not pushed by an economic interest. In my country, regardless of whether you offer prenatal or postnatal, there's no economic advantage. I think that would be us. We're still mostly doing our cases postnatal, and we're looking long and hard in order to make this decision whether we should make this transition. But it's very interesting. I'm still doing these cases from time to time.
Thanks. Thank you.
Thank you.
Thank you very much. Dr. Thompson, I know that we can go for another 5 hours with questions. In terms of, you mentioned about the outcomes, and I read your review in 2023 about not there being systematic outcomes to assess the fetal surgery. Is there any efforts being done on that? Or is it like the Caceres that we will be again in 20 years' time talking about the same thing?
No, I think there is recognition that we now have to be more granular in looking at outcomes. I think hydrocephalus, hindbrain herniation, and motor, they're fine, but I don't think they're going to be sufficient in the longer term for us to be able to work out whether fetoscopy by this particular technique is any better than open and postnatal. So I think, as Samer said, I think particularly cognition, urinary function, there's a lot of metrics that could be looked at in the future.
That's brilliant. Thank you very much to all the participants. I appreciate this is at least in the Northern Hemisphere, summertime. And I think it shows about neurosurgeons how much we are passionate about our patients, about our subject. And thank you for all those who participants who came. If you have any questions, please send it to me. You have got my email. I'll forward it to the speakers or to the faculty. And once again, I thank the faculty. I think this has been, one of the very special webinars we have had. Amazing faculty and speakers. I think this is a landmark webinar in that sense. So thank you for your time, Mr. Thompson, Dr. Caceres, Dr. Borkar, and Federico. I know that Federico is busy doing the ISPN Congress, so I really appreciate taking time to be here. And I think we should have something on Chiari and other pediatric spine topics. I will contact Mr. Thompson and Federico and the team. And thank you very much to Professor Fieggen. It really was fantastic to connect with you again and to get your lecture and have you. I think once I said that Professor Fieggen was here, everything came quite nicely as well. So thank you very much, Prof. Fieggen. And Dr. Samer Elbabaa, thank you so much for this lecture again. I know that I initially said it's a lecture, then I built and built. But thanks for your time for us. Once again, shall I leave Professor Fieggen to give us the closing remarks, Prof. Fieggen?
Naren, thank you. I think it's been amazing to be part of this webinar, and I think we've all learned a great deal. So thank you. And thank you to everybody for spending time on a Sunday joining.
Thank you.
Really nice to be part of it.
Thanks.
Bye-bye.
Hopefully meet again.
Take care.
See you all in Lyon.
See you
Thank
in
you.
Lyon at the ISPN.
Yes.
Yes.
Thank you.
Wonderful.
For
Bye.
those who need,
Thank you.
we can send visa letters for those who might need it.
Thank
Bye-bye.
you.
Thank you, everyone. Bye-bye.
Thank you.
Bye.
Thank you, Federico.